Thank you. So these are my disclosures. Everyone in this room obviously knows, enhanced recovery after surgery. I don't have to go through it too much, but we all know decreased length of stay decreases complications, less the healthcare resource utilization, and increased patient satisfaction. At McGill, we've had a ERAS program since 2008. It's undergone multiple iterations, progressively including the new emerging best evidence, and we've also applied a lot of the enhanced recovery principles to many different specialties. So basically, any inpatient operation within the Department of Surgery now has an enhanced recovery pathway. Within colorectal specifically, kind of up until relatively recent, no matter what we did, our target length of stay was about 2 to 3 days. And again, no matter what we did, about 2/3 of patients were discharged within 2 to 3 days, and we couldn't really ever get that much better. It's pretty good, right? 2 to 3 days post-patient, compared to when I started my general surgery residency, we were waiting for gas before we were treating people, and then the length of stay was 7 days. We wanted to say, could we make this better, right? Do the patients really need to stay in hospital for the 2 to 3 days? Because increasingly we just kind of saw that, as I'm sure you remember as a resident, you'd look at the patient, and you're like, are you okay? They're like, yep. Did you pass gas? And you're like, yep. And then you kind of look at each other very awkwardly, not knowing why they're still there and what you're supposed to do for them. So when other people have looked at why patients are still in hospital after laparoscopic surgery within an enhanced recovery pathway, and kind of within post-op day 0, post-op day 1, post-op day 2, the main reason is just really not passing gas. As you stay longer and longer, obviously the other reasons tend to be more and more common. So overall, we know that even within an enhanced recovery pathway, a large proportion of patients just kind of are sitting around in hospital waiting to pass gas before we send them home. So can we do better? Back in the day when, and again, this is not meant to be derogatory in any way, but traditional conventional care, when we used to keep patients until they were passing gas and stool and tolerating diet, they were staying about 7 days, and kind of they look like this more or less, to enhanced recovery, and then hopefully now to outpatient surgery. So how do we get from at least the middle, which I assume everyone here is doing, has an enhanced recovery, the middle to outpatient? So these are some of the things that we had to consider prior to instituting our same-day discharge pathway at McGill. So is it safe to send patients home before recovery of GI function? Are we able to manage their pain adequately at home without kind of the IV sub-Q breakthroughs? And are we able to monitor post-discharge progress remotely? So when you look at the PO, the kind of return of GI function, which probably is the main thing everyone's worried about, we do know that if you're not able to tolerate oral intake in the first day or so, this is usually associated with worse outcomes, more complications, longer hospitalization, more unplanned reoperations. And when we looked at our own data, we saw that if you're able to tolerate liquids on day 0, so you're able to drink at least a cup, 300 cc's seems like a pretty precise measure, but it was literally just the cup we gave patients in the PACU. So it was just are you able to tolerate this or not? And without having a lot of nausea, without giving a lot of antiemetics, or without vomiting, if you're able to tolerate in PACU on the first day, they tended to do really well. So this is a graph showing the IFEED score, which I'm not going to go into too much now because I think we're going through it after. But basically, if you do well initially, you're going to do well. And about 69% of patients did really well. And again, just to show, so these people who did well had a faster kind of overall return to a full bowel function, shorter length of stay. They almost all left by target discharge, less complications, and particularly almost no one required an NG tube. And we're not the only ones to show this. There are other people both in Europe and in the US that have shown that it's safe to discharge patients prior to return of bowel function. We can say that GI recovery is uncomplicated in most patients, and most of the time you can just leave them alone. Even if they have a little bit of nausea, vomiting, or a little bit of GI intolerance, you don't really have to do anything for them, right? You just kind of tell them, don't be an idiot, don't eat steak and fries if you're having nausea, just have a bit of water. And we also know that if you're able to tolerate liquids very early, then you're pretty much gonna be okay. The second thing is what we wanted to look at is, are you able to manage their pain properly without giving kind of inpatient pain medications, quote unquote. So the two approaches that we decided was really kind of trying to say, can we make better incisions? And as well, are there other medications other than opioids that we can give? And these things are obviously we can give orally and at home. So we've really transitioned going from a like periumbilical midline / lower midline for our laparoscopic cases to a fan and seal for pretty much everything. This does require intracorporeal anastomosis for proximal colonic lesions. But when you look at the fan and seal, they're kind of transverse incisions, and we've shown this within our own data, both with randomized trial and kind of prospective data, that a fan and seal or transverse has fewer wound complications and less pain. And when we looked at fan and seal specifically, about half patients didn't require any opioids at all on day 0, and about a third on day 1, about half again don't require any opioids on day 2, and by about day 3, almost no one required opioids. And kind of obviously, if you look at overall, there's a much lower mean overall morphine equivalents given over the first 3 days. And we're not the only ones to show this. Many randomized trials have shown that off midline transverse incisions, so like fan and seals, are much better than midlines, associated with much less pain and much less opioid requirements and analgesic uses. And as well, when we kind of started within our ERAS program about like 5 years ago, we were giving PCAs to everybody, and we've moved away from that and only PCAs as needed. And we're really, really heavy on NSAIDs. And again, think what you will about the data about NSAIDs and anastomotic leak. When you look at the data overall, there's not a really good kind of association with that. So we're very, very liberal with our NSAID use, and we are very, very liberal with our regional nerve blocks. So a lot of the transverse abdominis plane blocks. And kind of, again, using these opioid adjuncts, as well as kind of off midline incisions, we show that you give less opioids, and obviously less opioids is associated with with faster GI recovery. So in terms of what are some of the strategies that you can adopt to minimize pain is like smaller, better, and less painful incisions. So just use a fan and seal, right? Just use a fan and seal, or at least an off midline transverse. Try as much as possible to avoid opioids, and there are a lot of drugs now. We don't even have IV Tylenol or the liposomal bupivacaine, which I can't remember the name of right now, what it's called. But if you have that available, doing tap locks with that will last almost 72 hours versus just the standard bupivacaine that we use for our tap locks in Canada, because we don't have liposomal bupivacaine yet. And obviously, we all know that trying to avoid opioids is better, and it's associated with less postoperative GI dysfunction. And lastly, and probably one of the more important ones as well, is are we able to monitor their post-discharge progress remotely, right? Because everyone feels a little bit uncomfortable just like asking patients to go home and having really no contact with them afterwards. And a lot of studies have looked at kind of the patient experiences after discharge from a variety of procedures. And a very common theme across all of these is that patients have a lot of concerns about access to their healthcare provider for additional information if they have any concerns or if there's any complications. And if you can't get reliable information or you're really worried, you just end up at the emergency room. And so, we're at this nice little Venn diagram intersection of having this need and having the available tools for this. With everyone basically having a smartphone, and there's a million different apps now, mobile health apps that are commercially available for post-discharge monitoring. We just use CareSense for no particular reason. And within this, we just basically included our patient education booklet, so the standard ERAS one that we have. We didn't really invent anything. We included a daily 5-item questionnaire that patients started answering at discharge in up to 7 days. And it's very simple. It's just like a virtual round. Is your pain controlled? Are you able to drink without nausea? Are you passing gas or bowel movements? Do you have a fever? And is your wound leaking? And as well as part of this app, there's a HIPAA-compliant patient-physician communication feature. So basically just like a secure chat that they can also send pictures in. And when we started, and this is kind of pre-same-day discharge, when we just started using this app, we showed that we were able to decrease the number of preventable ED visits. So again, the visits that they kind of come in, and everyone has experience with this. Like patients come in, they're like, oh, my wound looks funny, or I'm concerned about my wound. And then you kind of look at it and you're like, I don't know, it looks fine. Like, why did you wait 12 hours in the emergency room for this? So we prevented a lot of these unnecessary ED visits. But importantly, we were able to show that patients who had real complications, so the ones that had like fever and had a leak or had some like actual thing that we needed to intervene on, they almost all contacted us through the app. So we were able to actually identify all of these adverse events through app-based interactions. And when the patients are very, very satisfied with the app, they feel really safe, they feel like the ability to kind of like communicate with their healthcare provider. And just before someone asked me, it's a combination of the surgeon, the resident team, as well as our nurse clinician in our clinic who responds to the app. And the average, and you would think that like you're like, I don't know if I really want to like have a chat function with like patients, but most patients are really like reasonable about this. Like the average number of like messages that we get back and forth is about 5, because otherwise you would think that you want to be answering this like 24/7. And so when we look at our mobile health, or telehealth, or whatever else you really want to call it, our experience, we showed that it was effective in improving patient-physician communication, especially in the post-discharge setting. It's really useful for post-discharge monitoring. It may prevent unnecessary ED visits, and importantly, we're still able to recognize any potential adverse events in abnormal postoperative courses. So when you look at kind of these 3 things, like, is it safe to send patients home before recovery of GI function? Yes. Most patients have uncomplicated recovery, and most of the time you don't have to do anything for them, and really they can have their GI recovery at home if they're just gonna have clear liquids at home. Can we adequately manage their pain? Yes, with kind of using fan and seals and tap blocks, as well as non-opioid medications. And can we monitor their post-discharge progress remotely? Yes, we used an app. Other people have used telephones, telephone calls, or available, and there's many different ways to do this. So kind of putting this all together, we started our same-day discharge outpatient protocol, whatever you want to call it, in February, March of 2020, so right before the pandemic. These were our inclusion criteria. And again, it's really like not for everybody, right? We're not gonna send the like 95-year-old who has like COPD home on like day 0, right? So these are gonna initially, or which when you start out, you're gonna initially choose the like, you're gonna be highly selective. And importantly, the thing for us is that we needed patients to have a smartphone so we can install our app. And again, that was just one of our main criteria. We initially excluded all IBD patients because we didn't want to give NSAIDs to them. We've since kind of ignored that, and we now include IBD patients because we give them NSAIDs. And we no longer require them to have a virgin abdomen, because a lot of times people just have like hysterectomies or something and that really doesn't change anything. So our discharge criteria, again, just follows a lot of the kind of background data we've done. They had to tolerate oral intake, so at least that little cup of liquid that we gave them in the PACU without any nausea and without having anything more than a bit of Gravol. Their pain had to be adequately controlled on oral analgesia, so that was, and again, there was like nothing fancy. We didn't use pain scores, we just looked at like, is your pain controlled? Like, do you feel okay? And they said yes, then it was yes. And they're able to pee and they're able to ambulate. So again, really like nothing groundbreaking, nothing super complicated. Our very first patient was February 13th, 2020, right before the pandemic. It was a lap right that we, again, did a fan seal, we did a tap block, a short operation. This guy stayed in PACU forever because we were like terrified and we really wanted to make sure that he was okay, but our mean PACU length of stay now has gone down to about like 2-3 hours. And this guy, you can see, didn't really have all that much additional analgesia in the PACU. Since that first patient, we've recruited 114 to our outpatient protocol out of an overall of 433 colorectal resections. So this was over the pandemic, so kind of take some of the numbers as you will. And again, I just wanted to point out that, again, it's not for everybody, right? So only about a quarter of patients of our overall cohort, and again, it'll depend a bit on your practice patterns. We do a lot of rectal, we do a lot of referral redo surgery, so only about a quarter of patients are kind of recruited to same-day discharge, and only about half of the people who are even eligible end up in same-day discharge. And again, it's kind of, you can see the demographics is pretty standard. So of these 114, 84% are discharged on post-op day 0. There's about 15% of patients who remained for either kind of medical reasons that we kind of did something to them in the OR that we're like, oops, you probably should stay, or they failed our discharge criteria. Mostly it was because patients kind of were like, nah, I'd rather stay for a day, which was fine. And of the people who left, we only about had 5% who came back within the first 72 hours, and that was considered a quote-unquote failure for us. So overall, we had what we call the 79% success rate, which again was DC on day 0 and no readmit within the first 72 hours. When you look at the patients who kind of had to come back from the first 72 hours, like 2 of them came back for an anastomotic bleed. One guy came back from an evisceration from a stoma site, which never happens. One guy had a very early leak, which was more of a technical failure. One person had urinary retention, and one patient had a small bowel obstruction from a perinastomotic hematoma. And again, when you look at our base compared to both kind of pre-COVID and kind of and during the time when we were using our mode discharge app, the outcomes were pretty much the same. The numbers are almost identical. So in summary, I just kind of hopefully showed you that outpatient colectomy is safe and feasible in select patients, and again, I want to emphasize the select part, and this is because GI recovery is mostly uncomplicated. Pain can be well controlled with better incisions and with minimal opioid requirements. Remote monitoring, remote follow-up, whatever you want to call it, and however which way you want to do it, and we'll go through it a little bit later in the session, is effective. And outpatient colectomy may reduce inpatient burden and unnecessary healthcare resource utilization, and that data will be presented today. And importantly, a lot of these principles can be applied to other procedures with short target length of stay. So now we do outpatient bariatrics, we do outpatient pulmonary lobectomy, taking into account a lot of these principles that I just showed you today. So thank you, and I'll guess we'll do questions later, right? Okay.
Exactly.
Yes, all right.
Well done.